Hello, welcome to Adapt NCLEX. I want to talk about a couple of very important topic you have to know. Code for your exams. Expect to get questions on them no matter what. This is very important because it's real life. You see it all the time and you see people have this problem. So we have to know something about it as nurses. So let's get to it. Before we start, like you said, you know me, I always like to break everything down so that you can see why this is happening. So we'll talk about the anatomy of the adrenal gland. So adrenal gland, it sits on top of the kidney. So if this is the kidney, okay, the adrenal gland just sits right there. It's like a heart on top of the kidney. It's very small. It's almost like 4 grams. So it is the adrenal gland. So this is the gland. It has 2 parts. It has the inner portion, which is called adrenal medulla. It's a fancy word. And the outer core, which is what we call the cortex. There's 2 parts because they do different function, a very important function. The medulla secrete catecholamines. So catecholamines, which are like norepinephrine. So this is where you get your epinephrine and norepinephrine from. And so this is where you get, and sometimes dopamine, okay? They are all part of it. Dopamine. So these 3 catecholamines comes from the adrenal gland, very small organs, but it's very, very important. That's why you have to know every bit about it. These catecholamines, so they're involved with your stress, flight and fight information. You see a snake, you run away, it's adrenal gland. The cortex is divided into 3, and I call it GFR. And it starts from the outside. So the G is on the outside. So it's called glomerulosa. And this is where salt is secrete hormones that control salt. And in the middle is the fasciculata. It secrete hormones that control sugar. And then the inner portion is reticulata. It secrete hormones that control sex. You don't need to know the names, but you have to know the S's over there. And the way I remember them is the deeper you go, the sweeter it becomes. So salt, it doesn't taste good, but sugar tastes a little bit better than sugar, and sex is better than sugar. So the deeper you go, the sweeter it becomes. So outside is where you produce salt and sugar and sex hormone. So the hormones that is secret is aldosterone. You see, aldosterone control salt. And then sugar is corticosteroid. So this is corticosteroid that control your sugar, and your sex hormones are androgens. These sex hormones are very important, mostly testosterones. Men have testosterone from their testicles. Women don't have it. So for women, this is where you get your testosterones. So if your adrenal gland is affected, it can affect your growth. So this is involved in puberty. So this is what helps with puberty, pubic hair growth, and everything because of the hormones that is secreted. One more thing, the F and the R, which is the steroids, corticosteroid, and the androgen are controlled by ACTH. ACTH, as you can remember, is coming from the anterior pituitary gland. And then tell the adrenal gland to secrete corticosteroid and androgen. So just remember, we will apply it. This is coming from the adrenal pituitary gland, and it secretes those information to help them stimulate that. Okay. There's 2 things you have to know. the adrenal gland, it plays a major role. And when you don't have it, you can get into trouble really quickly. So what happened? Well, why do we have something we call Cushing? So like I told you, the adrenal gland is involved with those hormones. Sometimes these adrenal gland make too much, there's too much steroid. Cushing means too much corticosteroid, mostly corticosteroid, okay? Which is the main function is to increase your sugar. So corticosteroids, too much of it. There can be two ways this can happen. Either the adrenal gland itself as a tumor that is secreting too much corticosteroid, okay? Or you have too much ACTH. Remember ACTH from a pituitary gland, anterior pituitary, that causes the adrenal gland. It tells the adrenal gland, so adrenal gland make more corticosteroid. If you have this one, ACTH is produced. Remember, ACTH will cause more steroid and more androgens. So pay attention. So this is what happens. So that's what we call Cushing. You know, Mama, I'm not using Cushing syndrome or Cushing disease because that's what the point I'm trying to make. If you have Cushing disease, it means the steroid that is increased is coming from ACTH. So you're making ACTH that is telling adrenal gland to make more steroid. If you have Cushing syndrome, that means you're taking some steroid from outside. So this is coming from the outside or to the adrenal gland itself, adrenal gland making steroid. So there's difference between them. Cushing disease means ACTH causing the adrenal gland to make more steroids. Cushing syndrome, you're taking a pill and you're looking like somebody who have Cushing disease. That's why it's called Cushing syndrome. It's a collection of that. Or the adrenal gland making too much steroids. And therefore, that is corticosteroids. And that's why we call them Cushing syndrome. I don't think they will play that trick with you, but just to let you know, in case you see it, you say, why did they call it disease? Why did they call it syndrome? They are the same. One is ACTH causing more steroid. The other one, either you're taking by a steroid by mouth or somebody who eat too much steroid by mouth or somebody, the adrenal gland is making steroid itself. There's difference between them. So based on the function of steroids, okay, steroids. When we say steroid, we're talking about corticosteroids. Based on the function, you can deduce signs and symptoms. This is why I keep on saying your test is basically pathophysiology. You can deduce signs and symptoms. Steroids usually it causes you to be in a stressful situation. In that form, when you're stressed, you have to make something to help with that stress, and that is glucose. So increase glucose. When you stress, your glucose increases. So it helps with stimulation of more glucose, making breakdown to produce more glucose for your energy so that you can fight that stress. Okay, so that is what happened. Stressful situation. Then what happened? Steroids also will lead to production of more fat. So you deposit fat. It doesn't allow fat to break down, but it makes fat to be deposited. So when you eat, you store more fat, and so you have storage of fat. Unfortunately, these people, when they have too much steroid, we call it lipodystrophy. The way where the fat is deposited is specific. It goes to the back of your neck or in the abdomen for if it's due to steroid. And these people have, that's what we call the buffalo hump. And they have the truncal obesity. You see, that's why they have these features. So truncal obesity. The next one is on their face. The fat gets deposited on their face. So you have the moon face. So there's a reason why they have those features. They have moon face because that's where the fat get deposited. Truncal obesity because they go into the abdomen because it's the steroid that is directing them to go to that place. And the neck, they have at the back of their neck is buffalo hump. In your case, they can write those that means back. Cervical, okay, fat. It's the same thing. Back of your cervix, fat at the back of your cervix. So those are cervical fat is the same thing as buffalo hump. So that's what these people are. If you're not breaking down your fat and you're storing it in your abdomen, your face, and your neck, what do you think will happen? You gain weight. So weight gain with the steroid. This is why this is happening. Okay, they start gaining weight with their steroids. And so then after they've gained weight, steroid also affect collagens. This is what keeps your skin really tight. It doesn't stretch it too much. Where if it decreases collagen secretion and it affects what we call the skin. So the skin become very thin, so atrophic. So they have very thin skin, very thin skin. If the skin is very thin, it also stretches because it doesn't have the collagen to let it come back, rebound back. So that's why they have the abdominal striae. Like they have pregnancy, but it's different. The distance between those striae are very long. And very, so that's why they have these features. So this is why this is happening. Steroid also make your bone to break down. So bone breakdown, and that lead to osteoporosis. You see, I'm just using the function of steroid to give you signs and symptoms. It's also an anti-inflammatory. So people who take steroid, they are immunocompromised. If you immunocompromise, what will happen? You have high risks of infection, increased risks of infection. You don't have to memorize it. You just have to deduce those information. Increased risks of infection. The only thing I cannot explain is depression. People who are on high dose of steroids, they can get depression from it. That's the only thing I cannot explain. But one more thing, a couple of them that I can explain. Okay, so steroids, it will lead to fluid retention. So what it does, it acts like aldosterone, but it's not a true aldosterone effect. So what it does is it makes you hold on to your sodium. That's how you gain weight and the fluid. So you increase sodium and increase water. Whenever you're holding on to these people, you have decreased potassium. You see what they can do to you. All these things they can put in the SATA form, but you can deduce them from that. Okay, so high sodium, high water, and low potassium. What do you think this lead to? Well, fluid overloaded. So you have fluid overload. So we've turned to cardiac right now. all the symptoms of fluid overloaded. Don't be surprised when they ask you, they're talking about Cushing, now they're asking you somebody with a headache, hypertension, and don't be surprised. That's how you can put everything together. So don't memorize it. This is pathophysiology and the real life. You're learning to apply it on the floor. So they usually hypertensive. They can get headaches. All the symptoms of fluid overloaded is connected in that way. Now, they can remember the ACTH. If it's very high, then androgens is going to be high. If androgen is very high, which is a sex hormone, they have acne. So that's why these people have acne. They also have hirsutism. So very hairy. So female with a lot of hairy hair on their body. They get mustache. So this one is all from the androgens. That is androgens that is being produced from the Cushing effect. Okay, so this is all. Then there's one thing when I was doing this, I thought about that they can trick you. So a patient who have 3 Ps, right? Polyphagia, polydipsia, and then polyuria. What is this? Be hungry all the time, thirsty all the time, and then peeing all the time. This is from diabetes. This is all glucose related. Steroid can turn it into diabetic. So they become insulin resistant, and these are all steroid. So it can make you have the 3 Ps of diabetes. So hyperglycemia. So that can happen. Okay, so that's all related to that. Now, what do you tell this patient? Okay, what do you tell this patient? Well, all they have is too much steroids. They cannot stop. If they're taking the steroid by mouth, do not abruptly stop steroid. And we will go there. If they're taking steroid by mouth, that means this is by mouth, okay? And they start taking steroids, the adrenal gland will say, okay, you're taking steroid, I'm not making any more. I'm not making any more steroid. Therefore, all you need to do is keep on taking your steroid, keep on taking it. If you need to stop the steroid, you got to taper it. So if you take 30 milligrams of steroid, you should taper it at least 1 week or 2 weeks, slowly, slowly. And what this does, it allows the adrenal gland to recover. Then the adrenal gland will take over and start secreting steroid again because you don't need it. There's a certain amount of steroid you need every day. So when adrenal gland knows that you have too much, it will shut down. And then if you stop taking it abruptly, well, you need some time to recover. If it doesn't do that, then you go into adrenal crisis. So we'll talk about that. So that's what happens. You have to slowly and taper it. Based on what we've done, you can teach a patient about what you expect in a SATA question, what you expect finding when what you need to see on physical exams. And guess what? They can confuse you between Cushing and Addison disease. And therefore, we go into Addison disease. Addison disease is basically you don't have the adrenal gland. This is the adrenal gland. It's shut down. It's shut down. So it cannot make any steroids. So no corticosteroids. It cannot make any androgens. It cannot make any aldosterone, which is involved with salt reabsorption and sodium maintenance. So you can see, you can deduce all the symptoms they're going to have. If you don't have steroid, well, your sugar go down, right? We talk about it. If you don't have steroids, well, your blood pressure go down, right? If you don't have steroid, instead of gaining weight, you lose weight. It's opposite. So whatever you know for Cushing is going to be opposite. So, right? And then what happened? The androgens, the pituitary gland will say, oh, there's no steroid, there's nothing. So they will make ACTH, more ACTH, telling adrenal gland, please, please make androgens. Unfortunately, ACTH cannot do anything because adrenal gland is shut down, but there's something on ACTH. High ACTH will act on melanocytes. These are melanocytes. That means the melanin on your skin, like you can see the dark people, and therefore it will stimulate melanin deposition more. So if these people have, they are not, they Caucasian, they have more melanin, and so that's what they have, like bronze-like pigmentation. This is why they have this bronze-like pigmentation. It's because ACTH is increased. They don't have any steroid, corticosteroid, hydrogen, or aldosterone, and they have made the ACTH that is produced now is acting on melanocytes, and melanocytes making this pigmentation. This is how they can trick you. This one, bronze pigmentation, or hyperpigmentation. They will use the word hyperpigmentation. It's very classic for adrenal gland. So that is something that you have to know. You know what aldosterone does. Look at my lecture on aldosterone, its function. Basically, in the kidney, aldosterone make you get rid of potassium and absorb sodium. Okay. And then he also lets you get rid of H plus ion. So he lets you get rid of it. So those are the two things aldosterone make you get rid of quickly. And so that's what he's going to do. Okay. They don't have aldosterone. Okay. They don't have it. So that's what aldosterone does. You get rid of potassium and then H plus ion. No, you get rid of potassium and H plus ion and let you keep sodium. So your sodium goes up, your potassium go down, and your acid go down. So usually, if you have aldosterone, you have what? If your acid going up, you're going to have metabolic alkalosis, right? These people don't have it. Therefore, what do you think they're going to have? Their lab work is going to show their sodium is down, their potassium is high, right? And their acid is high because they cannot get rid of the acid. So they have metabolic acidosis. This is in case they ask you in the SATA question. This is why adrenal insufficiency or Addison has metabolic acidosis. So they get weak because all this is coming from sodium. So sodium is low, well, blood pressure is low. They get dehydrated, they get weak. So, and all this is what we call shock, hypovolemic shock. So they can go into shock really quickly. The hypotensive and dehydrated, and it can go into shock quickly. The other thing that is classic for adrenal is GI symptoms. They have GI symptoms. like how diabetic patient going to decay. I don't know, because if severe dehydration, they have GI symptoms. So they have nausea, vomit, okay, and abdominal pain, like DKA patient. And so that is classic. So those two, GI symptoms and skin, bronze pigmentation is very important for the adrenal insufficiency. Okay, so those are, and you can see there's a couple of S's. Okay, but I don't like that. I don't like the S. If you read other people, they will say there's 4S and 4 small S. No, don't worry about it. If you understand what is going on, it become, I mean, it will make sense. Okay, the assault is going to be low. Yeah, small S is fine. Small steroid, small androgen, and small. It doesn't matter. Basically, if you know what is going on, you'll be able to answer any question. Like how I break it down into detail so that you can understand what is going on. Then anybody on steroid, which this one you shouldn't forget, they like asking is they can get ulcer, okay, gastric ulcers. So they need a PPI, gastric ulcer from steroids. So they need a PPI. But these people, they have no steroids, so it's not a big problem for them. Day two, they are risks of infection. Adrenal insufficiency patient, they are risks of infection. Due to their risks of infection. And the other thing they like asking, we already talked about it, but I just want to emphasize, because the salt, they don't have sodium, well, they will have salt craving. They will try to eat salt. I mean, they're dying for it. So one thing you can see is adrenal insufficiency. If they bring this ACTH, okay, versus Cushing, okay, Cushing. What do you think? Well, adrenal insufficiency, you should expect the ACTH to be high, because if you have too much steroid, it tells the pituitary don't make ACTH anymore. So there's a negative feedback loop. There's a negative. If you have too much steroid, ACTH will not be produced unless there's a tumor in the adrenal gland. And so in adrenal insufficiency, you have more ACTH. In Cushing, you have decreased ACTH. That is Cushing syndrome. But if it's a Cushing disease, yes. So that's why I don't know if they will ask you. Cushing disease, ACTH will be high. But if they say Cushing syndrome versus adrenal insufficiency have high ACTH, and Cushing syndrome have low ACTH. So how do you want to treat this patient, or counseling treatment? Well, when they come in, just give them what they need, okay? So they need some steroids. They need a couple of steroids. They need steroid that will give them salt. They need steroid that will give them sugar. So the salt one is aldosterone, but we cannot give you just aldosterone. There's another steroid. We call it fluorocortisone. And then sugar is corticosteroids. So there's two types. When you see fluoro in front of corticosteroids, it means it's giving mineralocorticoids. It gives you salt. It improves the adrenal aldosterone. It's going to do the same thing as aldosterone, and then you give them sugar steroid, which is regular steroid. There's few things that causes will make the adrenal fail. It can be from Usually it can be maybe autoimmune disease can do that. Sometimes TB, sometimes cancer can go into the adrenal gland and destroy the adrenal gland. Or if you have TB or you have autoimmune disease that destroy the adrenal gland really badly. Okay. This is where the fact you have to know. Okay. For these people, they have no steroids at all. There's no steroid, there's no mineralocorticoids. So the blood pressure is going to be low. They cannot make sugar. So you got to give them sugar. You got to improve their blood pressure. So what you tell them is, okay, what you tell them, based on this, they cannot take stress, like infection or surgery. When you stress, you make more sugar to help you be able to run away, do whatever you want to do. When you sick, you need more sugar. When you're going to have surgery, it's a form of stress, so you need more energy, more sugar, more steroid to keep you moving. These people, if adrenal glands shut down, no way, they can't do that. So adrenal insufficiency patients in times of stress, one, infection or surgery, you educate them. So educating and teaching, expect this to be a SATA question. In this stressful situation, infection or surgery, increase your steroids. So if they're taking 20 milligram of steroid, well, if you get sick, we may need 40. If you're going to have surgery, you have to increase it to 40 before surgery. In a stressful situation, your steroid amount need to be increased before you undergo that. Otherwise, you get sick. So that is very, very important. The other thing to touch on, because the immune system is down and they are risks of infection, any small fever, you need to call the doctor, because then they will go into infection, severe infection, sepsis, and they cannot take stress anymore. So small infection, small signs of infection, urinary symptoms, runny nose, low grade temperature. Hey, you got to call your doctor, because when you are full blown sepsis, well, you can't take stress. You need your steroid. You don't have enough steroid to fight this problem, so it becomes a problem. We got to fix you. So that is very important. That is a good teaching you have to tell the patient. Otherwise, they will go into shock. The last, adrenal insufficiency is the is connected to Cushing. So if like you have somebody with the COPD, they be on steroid for a long time. Like I said, the adrenal gland will shut down. So shut down. Because of that, if they have to come off on the steroids, they have to take time, maybe sometimes 2 to 4 weeks, sometimes 1 month to be off the steroids. Slowly, they need to what? Taper it. If they don't taper it, the adrenal gland will not have time to take over and make the daily steroid that you need. And that happens, they'll go into adrenal crisis. That's what we call adrenal crisis. Or it's the same thing like somebody who has adrenal insufficiency and they get sick and now they are in adrenal crisis. Or somebody is adrenal insufficiency, they go into surgery and they get sick. So for this patient, you got to tell them to taper it slowly so that the adrenal gland will take over. If it happens, adrenal crisis, you know what is going to happen. Their blood pressure is low, their sugar is low, their heart rate is high. Basically, they are in shock. The best thing to do is give them fluid, and number one is steroid. So give them corticosteroid and fludrocorticosteroid so that they can correct the problem that is happening. There's some few things that sometimes they can ask you. Adrenal gland, we already talk about it. It make what? Aldosterone. This is the salt, the G portion of it, the GFR, the G, the outside. The aldosterone go to the kidney and tell the kidney, I need more salt. Get rid of H plus and potassium. Therefore, they will be what? What do you think they are metabolic? They will be metabolic alkalosis. So that is that problem. Sometimes it happens. They have tumor in the adrenal gland that all it does is make aldosterone. That's what we call Conn's. If you see it, Conn's syndrome. Basically, is a tumor in adrenal gland making what? Aldosterone. And I don't have to bother you too much with aldosterone. You know what it does. I've already said it. I've given you the main pathophysiology, sodium increase, and this will lead to what? Fluid overloaded. And therefore, you can deduce what is fluid overloaded. Signs and symptoms of fluid overloaded. Headache, hypertension, all the signs and symptoms that is expected. Hypokalemia, you know what is going to happen. So you just put it together and then you see that, oh, this is all easy. It just come out from the pathophysiology. And therefore, I know the teaching I'm telling this patient, well, don't eat any salt, okay? You may have to increase your potassium. So some banana, okay? And then we got to monitor your blood pressure, okay? And cardiac arrhythmia because of the hypokalemia. That's not good. And what do you think is the treatment? Check my cardiac medication pharmacology or diuretic. You have to block aldosterone unless you remove the tumor. So the medication that block aldosterone is spironolactone. That is a classic medication. It will block them, so you can give them that. Or the other one, if they don't give you spironolactone, these are all potassium sparing and block aldosterone. Epinephrine, that's the other diuretic. These two are potassium sparing. They block aldosterone and they prevent aldosterone from functioning. So that's the Conn syndrome is tumor of the adrenal gland that only make aldosterone. So it give you blood pressure problem. The next one is his friend. It's like Conn syndrome, but it's not Conn syndrome. It's what we call pheochromocytoma. I told you adrenal gland it has two portions. It has the medulla and the cortex. This is the medulla. And this is the cortex. And this is what make all the steroid we talk about. The medulla secrete catecholamines. So it secrete catecholamines, which are norepinephrine, epinephrine, and dopamine. And so when you stress, this is the hormone that is secreted. If you see a snake, that's the hormone that is secreted. And you know what norepinephrine, these are vasoconstrictors. Epinephrine, speeding your heart. Basically, basic things you know, you can deduce the side effect or symptoms this patient will be having. For pheochromocytoma, the cytoma means it's a tumor, okay? So there's a tumor in the adrenal gland, in the medulla that is secreting this. And then the pheo is the fancy name of that. Basically, you can tell what is going to happen. And some books will call it, or if you heard it before, it's the 5 Ps, okay? You have epinephrine and norepinephrine and dopamine. You know what they do. They are cardiac medication that will ramp you up. You are in you are on fire every minute. So they get headache. Okay, they have headache. No, it's the 5H, sorry. They have headache, and then they have hypertension. Their hypertension, blood pressure is episodic. The blood pressure is normal right now, then it jump, like it keep on jump up and down, up and down. So episodic, and then they have hyper, it's a fancy word, hyperhidrosis. That means they sweat a lot. You know, that's what epinephrine does, right? And then they will have hyperglycemia. That's how you're able to run away from the snake, because the epinephrine and norepinephrine, when you see something you scare, your adrenal gland secrete it, and then they'll cause your body to make more glucose so that you can run away from the problem. So that's how so you have a headache, hypertension, and a hyperhidrosis, and the hyperglycemia. So that's how, those are the side effects of that medication. And then the last one is hypermetabolism. So they break things, the metabolism quickly, so you can see if your metabolism is high, where you lose weight. They're eating all the time, they're breaking everything down to, because of the energy. They are like on fire. And so this is all the 5H, and you can use it to remember that 5H of the pheochromocytoma. Because of this, well, you, the nurse, what will you do? You're teaching, what do you think it will include? I mean, it's based on the signs and symptoms and the pathophysiology, you know. You need to give them high calorie. Okay, they have to avoid caffeine. If you eat caffeine, if you drink a lot of coffee, well, this is what caffeine will do to you. That's why you're on fire when you drink caffeine. They need to take frequent rest because they will be tired. And then this headache is episodic. And so when they get stimulated and they are in stressful situation, all this thing will ramp up. So they need a quiet environment. It has to make sense. When they give you answer choice, it has to make sense. Why quiet environment in the pheochromocytoma? Yes, because of the stressful situation will make them produce more epinephrine, no epinephrine. They will get headache, hypertension, sweaty, the sugar will go up. So give them quiet environment. And the tumor is usually is where the kidney is at your back. Okay, usually it's retroperitoneum, so it's at your back, and adrenal gland is sitting there. So when you do exams, costocervical CVA tenderness, if you're doing CVA tenderness, you should avoid it. Don't push on it. When you examine the no frank palpation of the tumor, don't palpate it. No palpation. Otherwise, when you palpate the adrenal gland, you releases the norepinephrine and they have symptoms. So that's the teaching you teach them. The treatment, I don't know if they will ask you guys, but I will mention it. They need an alpha blocker and then before beta blocker. So alpha before B, so A before B for the treatment, because they have fluid down. Even their volume in the system is very low, so they usually hypovolemic, so they need a lot of fluid. And so even though they are hypertensive, they need a lot of fluid. They are hypovolemic. So you need to give them alpha blocker to open the system and then give them fluid. Then if they have tachycardia, you give them beta blocker. So alpha before beta, but I don't think they will worry you too much, except you have to know the name of the medication you give them. So the treatment for this is phentolamine. I just mentioned it so that you can know if if you've never heard this medication before, phentolamine, it helps with norepinephrine, epinephrine, dopamine. It blocks them. So somebody who have extravasation, okay, if you have IV and then they have extravasation of IV fluid that is getting norepinephrine, epinephrine, you should give them phentolamine. So if you are IV get infiltrated and you have extravasation of norepinephrine, in case you're giving norepinephrine peripherally, it has to be given centrally, but sometimes you need to give it peripherally. In case you're doing it peripherally and you have extravasation of that fluid into the under the skin, while the medication, the treatment is phentolamine, and that will block the epinephrine. Otherwise, it causes skin necrosis, and that is a reportable finding. You got to report it to the your manager. Anybody who have extravasation from norepinephrine is reportable. I'm digressing, but that's another key question they can ask you. So your treatment is phentolamine to block it. So that is a pheochromocytoma. Just know the age and the symptoms and what you nursing treatment, and then you'll be fine. So I think that's all those we have. Adrenal gland, very important. You see things that you can get from it. So I give you a SATA question. Expected assessment finding include, you read the last statement, you find the keywords and evaluate each answer based on what the keywords that you have. So you have a client diagnosed with asthma. So this patient has asthma. Somebody will say, why is asthma here? Treated with oral steroids. So he was on oral steroids for 6 months. You took it for 6 months. The client presents with acute abdominal pain, GI symptoms, after failing to refill his medication for 1 week. So he's abruptly, that's how I'm deducing, stop his medication. All these long 3 sentences is saying is the patient was on steroid, asthma doesn't matter. He was on taking steroid for 6 months and he stopped it 1 week, all of a sudden, now he has belly pain. So he's taking steroids, his adrenal gland will shut down. He said, well, keep on taking your steroids. Just let me know when you're ready to stop. But when you're stopping, stop it slowly. Take it like a month to taper it. So this patient never taper is, and therefore now adrenal gland is in trouble. And the key word is abdominal pain. Just tell me it's in adrenal insufficiency. That means he has no adrenal, he has no corticosteroid, he has no melanocorticosteroid, he has no androgen. So he's lacking sugar, corticosteroid, and aldosterone. Based on that, we make our diagnosis that is adrenal insufficiency. So we go, is blood pressure 90/40? Yes, because he lack aldosterone. So he's going to be hypotensive. Nausea, yeah. Adrenal insufficiency, you have GI symptoms. Finger sticks of 200. Well, that's not correct. He has no corticosteroid. Corticosteroid will increase your sugar. He doesn't have corticosteroid, so this is wrong. Those are cervical fat, buffalo hump. Well, this is for Cushing because he doesn't have steroid. He doesn't, so that's wrong. Asceticism. Well, the same thing. This is Cushing. You see what? They can combine the two so that you have to distinguish between them. Weakness. Yeah, that sounds right. He doesn't have aldosterone. He's dehydrated. He has no steroid, corticosteroid, no sugar. Well, he will be dehydrated. Salt craving. Of course. If I don't have aldosterone, I would take some salt on myself. And this is the way they will ask you questions. They will combine adrenal insufficiency with Cushing syndrome. And you have to go in between, separate the two, and figure it out. They are straightforward. You see, SATA questions are not hard. It's the pathophysiology telling you about the risk factors, education, judgment, and then teaching, and then content level. And you can figure out what it is, and you'll be able to break down the answers. You don't put them together, and then you'll be good. I hope you get a good endocrine lecture today, and good luck, and keep charging.